Let's now look at slide number 64. And we see in slide 64 a radial head prosthesis and a proximal ulna fracture also. We see certainly a plate over the proximal ulna, and we see a prosthetic radial head. And what do we notice about this constellation of injury? Well, first of all, the first thing to tell you is that this is, again, a Monteggia fracture. Monteggia fractures are any fracture of the proximal ulna that involve the radial head, from a dislocation in grade 1 to a complete radial head replacement in grade 2. So grade 4, rather. I'm sorry, grade 4. Okay, so it could be any, the constellations grade from 1 through 4, with the ends of the continuum being a dislocation of the radial head all the way up to the need for prosthetic radial head replacement. Now, in this patient, we see a prosthetic radial head replacement, and in this case, when the patient came to me, the patient presented with pain with extension, pain with rotation of the forearm. And why would this person present with pain if one looks at this film? Well, if you look at the film here, what do you see? You see that the capitellum is actually superior to the radial head replacement. In other words, what you're looking at here is an X-ray where the radial head and the capitellum are not in alignment. This person has a subluxing radial head. One of the problems here is that the patient went on to ligamentous failure, and the radial head became unstable. This becomes an unstable radial head replacement. This is problematic. And how would you know this in the clinic? Back to me, Dermot. One would ask, how do you know this in the clinic? I mean, my patients have pain all the time. When patients have a firm end point, and that firm end point produces posterior or lateral elbow pain only, not pain in the elbow flexion crease, but pain on the lateral aspect or the posterior aspect of the elbow, and one can hear a clunking or perceive a clunking as the elbow moves, that's a sign of radial head instability. The worst thing one can do as a therapist is continue aggressive efforts to regain extension, because we're just then contributing to further injury to the joint. It's important at that point that the patient be referred back for surgical assessment to determine if any intervention is necessary from a surgical perspective, and for guidance should one continue in their efforts to regain extension. So it's very important to pay attention clinically to the cues and clues that you get through end feels, right? Through end feels, and through sounds of the joint as it moves. Okay? Those are important considerations. Let's look at slide 65. Slide 65 is a CT scan of an intra-articular radial head fracture. And this patient did not have open reduction internal fixation. This patient went on to having a radial head resection, and had which used to be a common intervention. Radial head resection was a common intervention. This is in slide 66. Slide 66, we can see the radial head resection, and I have spot shadowed you the problem towards the wrist. When this person went on to have their radial head resection, and another unappreciated instability came to the fore, and that was an instability of the interosseous membrane. If one pays careful attention to the wrist aspect of this X-ray, one can see that the patient has now developed a positive ulnar variance. And the reason they developed a positive ulnar variance is simple. As when the radial head was resected, the interosseous membrane was not able to maintain the parallel arrangement of the bones, as we discussed earlier. When the interosseous membrane fails, the patient begins to piston the radius, or the radius begins a proximal migration. This creates an ulna that is too long when the radius migrates in a proximal fashion. That creates an ulnar positive wrist, causing ulnar impaction syndrome, and creates wrist pain. So now the patient has a significant wrist issue in addition to their elbow pathology. Slide 67 shows the correction of the problem through placement of a radial head prosthesis and treatment in a standard fashion by the therapist for radial head replacement. And so this is a person that came to my attention after the injury was sustained and the radial head was resected at another institution. The person came to the institution that I worked with, and the radial head was replaced, and we treated the patient as a primary radial head replacement with excellent results.